Hear me. And I want to welcome everybody, all of our attendees, of whom there are many, to this educational series the team at Circ Heart Failure has put together for advanced heart failure and transplant fellows. And thank you for making me feel heard. For fellows, early career faculty, people who are in advanced residency and advanced general fellowship and absolutely sure they're going to be heart failure doctors. And we welcome you all. We're really, really excited about this series. I'm Nancy Schweitzer. I'm the editor-in-chief at Circ Heart Failure. And through this series, you're going to meet most of our editor team, which is a fabulous group of people. We put together this series to focus on areas we think are of particular interest and excitement in heart failure and transplant, and also areas where we'd love to see more great science done and submitted to the journal. The person who's really responsible for helping us put this together is Dora Lowton. Dora is a faculty member at Columbia University in New York City. I'm at WashU in St. Louis. So I'm going to turn this over to Dora to introduce the whole series and introduce you to our early career team at Circ Heart Failure. We hope that those of you who find this really enjoyable will get involved more with the journal, and then we'll turn it over to our fabulous faculty for tonight. I told my co-presenters that I'm on the inpatient heart failure service, so I'm going to run quickly, but I'll be back on for the Q&A, I hope. So Dora, over to you.
Thank you very much, Nancy, for your kind word, and very nice to meet you all. And when I joined the team a few months ago, we made a conscious decision to put the spotlight on you, advanced heart failure fellow, junior attendings. That our goal was to really create both a meaningful education resource and a place to grow your academic career and collaboration. Out of many initiatives we launched, this series was born. We know fellowship program vary in exposure, experience, in the clinical application of heart failure medicine. Circ really wanted to create a safe, collaborative space where trainees and junior faculty can really connect, learn from some of the leading experts, many of whom are journal editors, program directors, and national leaders in their field. My name is Dora, as Nancy mentioned, and I'm the digital strategist editor for the journal, and I'm from New York. Our goals are pretty simple, but ambitious. We want to expand your clinical knowledge, facilitate meaningful peer and mentor connection, and give you direct exposure to the editorial and the research environment of Circ Heart Failure. Over the course of this series, you will meet our editorial team, learn from them, and gain insight into peer review, medical journalism, and writing for impact. This series is designed really for you, as I said, and just for you. So we encourage you to keep your cameras on. I'm not too sure if you can. I think we just kind of need to change our settings that you can open your cameras, ask questions, share comments, participate in the Q&A. And none of our speakers or organizers are really compensated for their time. So your engagement means a lot, not only for them, but also to your peers. So this is how we make this richer learning experience for everyone. I can share here, our program, we shared before throughout different emails you got, but our series really include 8 monthly virtual sessions and 1 in-person meeting in November in New Orleans in the AHA Scientific meeting, and we would love you all to join to all of them. The topics were handpicked by our editorial team to cover essential areas of heart failure, but also branching into medical journalism and innovation. As you'll see, our lineup features some of the most accomplished heart failure physicians in this country, truly top clinicians in their respective areas. And this is a living series. So we welcome your suggestion for topics we might have missed so we can make the next year program even better. So here I want to, take the opportunity. This is our first webinar, and it's very exciting. And we really want to open the door for you to join us as the digital strategist for the journal. If you want to work with us in a young, innovative environment, focus on advanced cardiovascular science and digital engagement, to collaborate with us and closely with all the editorial team, and to participate in journal initiative, including digital outreach, special features, and engagement strategies. All of us will gain valuable experience that can accelerate academic growth and career development, and really opportunity to invest some time and creativity into shaping the journal digital strategy and expanding its global reach. I really want to take a moment here to give a big shout out to Sarah O'Brien, our managing editor. Many of you know her from the emails you've received in the last few weeks. She worked tirelessly to bring this series to life. She couldn't be here tonight, unfortunately, but we are deeply grateful for her dedication. We have over 160 registrants for this series, which is incredible incredibly exciting. So if you want to apply to join us in the Young Digital Strategist team for the CIRC Heart Fellow Journal, just please email Sarah or me directly, and I'm happy to share more information. Leslie, again, I want to have a very special thank to you, Nancy, who is a professor of medicine, division of cardiology, vice chair of medicine of clinical research, associate director of the Institute of Clinical and Translational Science, but she's also the editor-in-chief of CIRC Heart Fellow. Without your support and suggestion and building together with us this program, we will never make it to life. So really, I really want to thank you for that. Also, I want to warmly welcome and thank our two phenomenal speakers for tonight as we discuss mastering hemodynamics. First, we have Dr. Fang, Professor of Medicine, Chief of Division of Cardiology, Executive Director of the Cardiovascular Service Line in University of Utah, but also Deputy Editor for the journal. And also Dr. Lewis, who is the Section Head of Heart Failure, Director of Cardiopulmonary Exercise Testing Laboratory, Medical Director of the Transplant Program in MGH in Harvard Medical School, and he's Associate Editor for the CIRC Heart Failure. So without further ado, I would like to hand it over to Dr. Fang to talk about mastering hemodynamics.
Fantastic. Thank you, Dor. Thank you, Nancy. Thank you, Sarah, Christine, all of you who are on, and of course, Greg, who's going to follow. Let me just share my screen here. So can you guys see all that?
Yes.
I'm assuming that's a yes. Okay, great. So number one, I think a lot of us on the call are heart failure doctors because we love hemodynamics. And what I'm going to try to do in the next 10, 12 minutes is just cover some basics. And I would tell you there's a lot to learn from the basics. We can certainly make things more complicated, but often we miss out on some of the simple clues clinically that are provided to us from simple observations. And then Greg will follow with 10 to 15 minutes of obtaining and interpreting exercise hemodynamics, which have really advanced our knowledge of not only heart failure, but exertional symptoms in heart failure. So to get started, I think there's some really important rules of the road, so to speak, when we obtain invasive hemodynamics. And keep in mind that I think about every single one of these points when I'm in the cath lab and doing a case. So, arguably, make sure that you understand that any measurement we make has got to be relevant to some sort of reference point. And the first thing I do when I walk into a cath lab is to see where the transducer is, because if it's not at the mid-chest, the values are really uninterpretable. Number two, the status of the patient's highly relevant. So we generally recommend, particularly in heart failures, best as possible is to do these in the unsedated situation, because of course sedation has a big impact on the hemodynamic status of the patient, as does, by the way, fever, tachycardia, a lot of other things that go into it. So always keep the context in mind. Number three, all of us are commonly read numbers, but I can't tell you how important it is to look at the waveforms themselves. And we'll see some examples here today. If you tell an interventional cardiologist there's a 70% LAD, any good interventional cardiologist is going to look at the angiogram themselves. So if you tell me the wedge is 30, I'm going to look at the tracings myself. Number four, it's a single measurement in time, and keep that in mind when we bring people to the lab. Now, in the situation of exercise, you're allowed to see what happens over time or with their perturbation, and that's really important. But many of the times, our numbers are done at rest. We're going to talk a little about respirophasic influences. They do matter. Heart rhythm, we'll talk a little bit about, for example, atrial fibrillation, a very common problem in the cath lab. And then, of course, what I like to always say about the cath lab is, we are not radiologists. We want to get an answer. All right. So if you're coming to the cath lab, the question is, what is the question? And are you going to leave with an answer? So those are just some background pieces of information. So a couple of comments before I get to this first very important set of data. is that there are three reasons to do invasive hemodynamics, and 3 reasons alone. So again, if you take away nothing from this lecture, keep in mind that there are 3 reasons to do an invasive hemodynamic study. Number 1, which is most common, is that you don't know what's going on. You can't, patients having complaints, patients hypotensive, the data don't make sense. This is the most common reason we do invasive hemodynamics, to tease out the hemodynamic status of a patient when it's unclear from the bedside. Number 2, anytime we're working up anybody for advanced therapies, for example, transplant and VAD, we have to get invasive hemodynamics so we can understand fundamentally the function of the right ventricle. And then finally, if you're entertaining a diagnosis of PAH, pulmonary arterial hypertension, that diagnosis cannot be made without an invasive hemodynamic assessment. So those 3 reasons: unclear clinical scenario, 2, advanced therapies, or 3, entertaining a diagnosis of PH. Those are the 3 primary indications to do invasive hemodynamics. Now, this issue of changes over time, this is actually one of Milton Packer's first papers as a first-year fellow, 1985. And they were testing milrinone and dobutamine back then. And Milton simply asked the question, well, what happens if we just put it in the line and see what happens? Maybe it isn't the drug. And what you see here is cardiac index, mean blood pressure, heart rate, LV filling pressure, right atrial pressure, and SVR over the course of 24 hours, the first being the first 30 minutes, and then you see the 2-hour, 6-hour, and 24-hour mark. As you can see, simply just watching the hemodynamics over time, things can change and change substantially here. So you see, for example, an LV filling pressure fall from 32 to 25, the cardiac index going from 1.5 to 1.8. So keep that in mind. There are points in time. Okay, let's talk a little bit about CVP for a couple of minutes. This is a CVP tracing, and usually most of us are called to the number in the right upper left-hand corner in parentheses, 12. So somebody calls me from the cath lab, Jim, your patient's CVP is 12. And I said, well, can I see the tracing? When I see the tracing, we got big trouble here, right? Because although 12 is modestly elevated, and for most heart failure doctors, 12 isn't all that big a deal, there are 2 findings here that really bother me, that this right ventricle, despite an RA of 12, is really in trouble. One is there's Kussmaul sign. The green line is inspiration. It's a respirometer, and you can see inspiration there in the middle. And normally the CVP falls by 2 or 3 millimeters of mercury. Here, it doesn't fall. This is, some people call this pseudo-Kussmauls, but it should fall. If it rises, of course, that's more traditional Kussmauls. And so this is a right ventricle that's unable to deal with the venous return of breathing. Because when you breathe in, you create negative intrathoracic pressures, which augments preload. And typically, because of the negative intrathoracic pressure, CVP goes down. But when you cannot accommodate the preload of inspiration, the increasing preload with breathing, the CVP goes up. And then number 3 is our very rapid Y descents here, which represents early filling. A very stiff, bad ventricle has to fill in early diastole. All the filling's got to occur there because of the diastolic dysfunction. And that leads to this very rapid Y descent here that you can see. A rapid Y descent is always an abnormality. And this constellation of findings, an elevated CVP, Kussmauls, and a rapid Y descent, all just from the CVP tracing, tell you this right ventricle is in trouble. The other great thing about CVP is it'll tell you everything else. So this is work from Mark Drasner when he was working with us at the Brigham, when he was a heart failure fellow, and he simply, with Lynn Stevenson's guidance, plotted 1,000 hemodynamic measurements in right heart catheterization. What you see in the upper left is CVP versus wedge. In the lower right, you see wedge versus PA systolic. And although it looks like a scatter of lines, you can draw a line through them, and the R value there is 0.6. And in general, this leads to a relationship where the wedge is roughly twice the CVP, and then the PA systolic is twice the wedge. So literally from the CVP, you should be able to anticipate what the wedge pressure is and the PA systolic pressure is by simply doubling these values. When this relationship falls apart, there's either RV dysfunction or there's pulmonary vascular disease. So keep this in mind, a really quick and dirty way to think about the rest of the hemodynamics on the CVP alone. And CVP, by the way, has been used in every single hemodynamic risk score we have ever used or calculated to look at outcomes of RV failure. This is a table I put together a number of years ago. What you see is the hemodynamic parameter on the left, definitions in the middle, cutoff values, and then the references. And you can see CVP is in every single formula. And in fact, Kussmaul sign alone, which would suggest that the right ventricle cannot handle the inspiratory preload of breathing, is also quite powerful. So another reason why the CVP alone is so useful in clinical practice. In fact, I always like to say, throw a central line in. It's a poor man's swan, because we can always get the SVC sat from that too. Okay, let's talk a couple minutes about wedge pressure here. This is a wedge pressure, you see in here in the parentheses of 14. And the question really is, what is this representing and what does this measure? Well, a wedge pressure really is a measure of left atrial pressure. And keep that in mind. That's a very important issue. It's not a pressure, it's obtained actually in the lungs. You blow up the balloon in the lungs, okay? And as long as there's blood not moving, it reflects the pressure that is right out after the lungs, which is the left atrium, not the left ventricle. And so this is really representation of left atrial mechanics. And you can see here that there's an A wave that's phase delayed from the P wave because, again, you're back in the lungs. You see a V wave here that's quite large. Anything that's twice the value of the A wave is considered abnormal. And then you can see a mean value here, the digital mean that the computer is calculating for you, which is 14. So there's a lot of numbers in here that are very important, but the V wave, remember, is a reflection of left atrial compliance. This is atrial diastole or ventricular systole. So you can get a big V wave if you've got too much blood for a given chamber or too stiff a chamber for a given amount of blood. So if it's too much blood for a given chamber, that's called mitral regurgitation. There's too much blood during ventricular or atrial diastole, and that's why you get this big increase in pressure. Or if the left atrium is stiff, for example, in left atriopathies or in heart failure, for example, in that situation, you're going to have too stiff a left atrium for a given volume, and that leads to this big V wave. Now, I think everybody's traditionally taught that the wedge pressure is a measure of the left ventricular end diastolic pressure. Well, it is and it isn't. It all depends upon when you measure the wedge. Because remember, there's a systole and diastole, and LVEDP is end diastolic pressure. So it's very important that if you're going to truly try to figure out what the left ventricular end diastolic pressure is, you have to look at here at end diastole, which follows the A wave. So the true LVEDP in this is not this mean. It's right where my cursor is. It's really at the A wave here. That's the true left ventricular end diastolic pressure. So you can see here in this cartoon that the left ventricular end diastolic pressure can be quite different from the orange line, which is a wedge tracing. And in the case here, normally, the wedge pressure is 2 to 3 millimeters lower than the LVEDP, primarily because of negative intrathoracic pressures. But you can see here, if you were to take a mean, that in this patient, because of the V wave, which is integrated into the pressure over time, that the wedge pressure is going to be much higher than the LVEDP. So, what measurement do you use? It all depends upon the question you're asking. If you're asking what is the pulmonary circulation seen, it's actually seen in left atrial pressure. If you're asking what's the performance of the left ventricle, that's when you want to know the end diastolic pressure. Of course, they generally correlate, but this is one of the largest series in some more than 11,000 patients showing the difference. And you can see there's a reasonable correlation, but I would point you to the upper left-hand corner up here. There are a significant number of patients that will have actually a low wedge, but a very elevated LVEDP. And this is really critical when you're trying to make the diagnosis. of pulmonary arterial hypertension. And this is particularly true when the PVR is high, or if you're very worried that this is actually pulmonary arterial hypertension. And in this situation, getting an LV-EDP can be very important. Atrial fibrillation. What is the wedge pressure in the EDP? This is a very nice study from a number of years ago from Europe, where they looked at the wedge pressure and the EDP and sinus rhythm and AFib. If you look at the figure here in the upper right, you can see on average, as I showed you before, that the wedge pressure and sinus rhythm is generally 2 to 3 millimeters of mercury lower than the LV-EDP. But in atrial fibrillation, the wedge often is higher, I won't say overestimates, but is higher than the LV-EDP, usually by about 5 millimeters of mercury. So keep that in mind when you're doing a right heart cath in somebody in atrial fibrillation, that you're probably, if you're measuring and it's a true wedge, that you're 5 millimeters of mercury greater than the EDP. The obvious question you're going to come up is, why are they different? Well, if you know the RR cycle length is long enough, they will become pretty close, frankly. But when you're in rapid atrial fibrillation, you're probably not going to see that as much, primarily because the left atrium is stiff, you're losing left atrial kick, and sometimes the mitral valve hasn't even closed. I'm going to skip that for now. And then a couple of comments about FIC and thermodilution. On the left, you see the original Damer paper. I pulled it from 1982. This was a study of roughly 100 patients who are coming to cath for coronary disease. And this is where the famous Damer 125 cc's per minute per meter square comes from, 1982. By the way, do you see this spread of data? The range in this paper was 50 to 250. 125 is in the middle. And this has actually made it into clinical practice 45 years later in every single lab I'm aware of. And here's the best part. The paper concluded that the use of an assumed oxygen consumption is untenable. That was the conclusion of the paper, although we do this in clinical practice here years later. On the far right, you see a paper from the VA that demonstrates that if you look at mortality, thermodilution output correlates better than the FIC, using an assumed consumption. And then finally, I'm going to conclude with resistance. Systemic vascular resistance is a calculated value. It's the pressure drop-off across the systemic circulation divided by flow or output. We're just given the filling pressures in the output. The SVR is very, very important. This is a shock paper. They'll probably talk about it in a month, but this is a paper from our center. Tom Hamp and some of our fellows put this together. We looked at 700 consecutive patients with cardiogenic shock. And you can see here that patients with low SVRs or low press or high pressure doses actually do very poorly. And on the far right, you can see this inflection point is at about 800 dynes seconds centimeters to the minus fifth. So an SVR of less than 800, particularly on drugs, is a very bad prognostic factor. Okay, so I'm going to stop. It's been about 15 minutes. These are my takeaways. CVP is a critical hemodynamic variable to interpret. Don't forget the waveform and respiratory response. It tells you a lot about RV performance. The wedge pressure is really a reflection of the left atrium, not the left ventricle. Although the most common cause of left atrial dysfunction is left ventricular dysfunction. I didn't talk about the mechanics of measuring it carefully, but we can talk about that in the Q&A. Thermodilution actually turns out to be reasonably accurate in TR. I didn't show you that data. We can talk about that in the QA too. And then again, the importance of interpreting the vascular resistance, although calculated, can be very important in the management and prognosis of patients, particularly with shock. Okay, that was a whirlwind. I see a hand raised. Dor, do you want to take this or should we keep going?
Yeah, I'm not too sure if he has a question or not, but there is another question on the chat. If there is any difference between obtaining hemodynamic when doing a right heart cath via brachial vein versus the IJ?
No difference. as long as you get into the heart, either way.
Yeah.
People have tried to leave PA lines in brachially. The problem is that you will get a DVT. So when patients need, invasive hemodynamic monitoring over time, we almost always leave it in the IJ. All right. I'll tell you what, we'll hopefully have more questions. I'm going to hand this over to Greg.
All right, great. Thank you, Jim.
Go ahead, Greg.
My screen. And then in presenter mode. Let me know if you can see the slides in presenter mode now.
Yes.
Okay, great. Jim is a tough act to follow in terms of talking about hemodynamics. I'm going to try to complement what he just said with some discussion about exercise hemodynamic measurements. And again, depending on the questions, we can go through all these slides or some of them, and can certainly make them available to those who are interested in having them. So basically going to cover 4 topics briefly. We'll talk about optimal acquisition of hemodynamic measurements during exercise. We'll talk about the really wealth of emerging data demonstrating that you do learn more about a patient during exercise, including prediction of future outcomes. And then we'll talk, if time permits, about how we think about hemodynamics in the context of how we're actually diagnosing heart failure, particularly in heart failure preserved ejection fraction. And then finally, how do we contextualize some of the measurements we make in the cath lab compared to other things that we should really be thinking about that may be limiting our patients when they exert themselves. So Jim mentioned, I think it was reason number 3 to obtain a right heart catheterization is to diagnose pulmonary arterial hypertension. And particularly with the evolution of the diagnosis of PAH, I'm going to share a case with you here. You can see these are resting measurements in an individual with a right atrial pressure of 5, wedge pressure of 7, and a mean pulmonary arterial pressure of 21, with a cardiac output by thermodilution of 4.2 liters a minute. So the PVR calculates to 3.33. The mean PA pressure is in excess of 20. The wedge pressure is normal. And so this patient fulfills diagnostic criteria for pulmonary arterial hypertension. However, when you subject this patient to exercise, you can see that instead of that single measurement in time that Jim mentioned, you're actually acquiring multiple measurements over different physiologic contexts, different amounts of volume return to the heart, and you begin to have a higher resolution phenotyping of this patient. There are some patients that may fulfill diagnostic criteria for PAH, and you exercise them, and their mean PA pressure increases steeply, and their wedge pressure remains very low, and you can confirm the presence of pulmonary arterial hypertension. In this particular case, you can see that the PA pressure increases with exercise, but the wedge pressure increases kind of in lockstep with the pulmonary arterial pressure, such that if we look at the relative increments and we look at the changes in pressure relative to changes in flow, we can see that our transpulmonary gradient remains essentially the same throughout exercise, but the pulmonary capillary wedge pressure increases steeply. And then we can look at the extent to which pressure increases relative to the ability to augment blood flow with exercise. And in this case, the pulmonary capillary wedge pressure cardiac output slope was at 5 millimeters of mercury per liter per minute. And importantly, this is the change in pressure relative to the change in flow, such that there is not dependence on exactly where the 0 level was in the context of the changes that we're looking at. In contrast, the transpulmonary gradient barely changes relative to cardiac output with a slope of 0.4. And this patient has a post-capillary predominance of their pulmonary hypertension unmasked by exercise. So exercise hemodynamics are really kind of gaining steam. Whether we look at the European scoring system or whether we look at the universal definition of heart failure, both now incorporate exercise hemodynamic measurements, either with invasive hemodynamic measurements triggered after initial steps of the workup, which is entirely appropriate in the HFA-PEF algorithm for diagnosis of heart failure preserved EF, or in the universal definition of heart failure, where we rely on evidence of objective cardiogenic pulmonary or systemic congestion. But important words in this statement is at rest or with exercise perturbation. So this is increasingly becoming recognized in terms of the value of subjecting patients to perturbation, so that we're not reliant on those singular measurements that Jim just showed can change over time per Milt-Packard's study if you just repeat the measurements in the same person on a temporal basis. And I oftentimes like to think about the Braunwald physiologic definition of heart failure, which is failure to pump blood commensurate with end organ needs, or to do so at the expense of elevated filling pressures. And I think we can add to this at rest or with exercise. So if your heart attempts to increase perfusion commensurate with end organ needs during exercise, but does so at the expense of a steep increment in filling pressures, that can be very helpful in ruling in the diagnosis of heart failure. So seminal work by Barry Borlaug and Maggie Redfield back in 2010, you can see that these red and green starting points are virtually identical in these individuals. But patients who were ruled in for heart failure preserved EF had these very steep increments, in this case during supine exercise, in the pulmonary capillary wedge pressure, whereas the normal or hypertensive controls had a increment in wedge pressure that was much more modest. Importantly, also, Barry's group has looked at the same patients having rapid saline loading, which is another physiologically relevant perturbation. But notably, in the same individuals, you can see the exercise perturbation on the right-hand part of the figure here resulted in greater separation of these groups than even giving rapid saline loading to try to differentiate the heart failure groups from the controls. Our group has looked at this concept of the pulmonary capillary wedge pressure cardiac output slope because we want to specifically see how much the wedge pressure is increasing relative to increase in cardiac output during exercise. We know that healthy individuals can increase their wedge pressures well in excess of 30 millimeters of mercury if they do enough exercise. But if you index that to the cardiac outputs achieved, they have normal wedge flow slopes. And so if we look at the wedge flow slope in patients with heart failure preserved ejection fraction, it's much steeper than in normal controls, so notably a positive wedge flow slope in all individuals is expected. This wedge flow slope has now been looked at across 27 studies. Shown in dark lines is patients with heart failure preserved ejection fraction compared to the gray lines, which is control groups. And you can see there's reliable differentiation of individuals on the basis of this wedge flow slope of more than 2 millimeters of mercury per liter per minute. Our laboratory focuses on doing exercise with this configuration, upright exercise. We have a first pass camera that gets used in some cases and not in others to image the right and left heart. Patients undergo incremental ramp exercise, and then each minute, because patients are breathing into the metabolic cart, we can measure mixed venous oxygen content as well as radial arterial oxygen content, and do true FIC cardiac outputs minute by minute in order to construct those pressure flow curves for both the PA pressure flow and the wedge flow and the right atrial pressure flow relationships. With upright exercise, you can, in the heart failure patients, typically do about twofold more exercise than you can do with lying down flat, particularly in obese patients when they lie down with their feet up above them. Upright does reflect physical activity that is more usual in daily living. And importantly, this can be done very safely, but it does involve a significant kind of logistical commitment that we can certainly talk some more about. We recently looked at whether or not you could perform invasive exercise hemodynamics without affecting your ability to measure other important parameters like peak VO2. And in this study of 74 patients who had both invasive and non-invasive cardiopulmonary exercise testing within a 12-month period without major intercurrent interventions, you can see that these same individuals had virtually identical peak VO2. 97 and 99% of patients were able to achieve respiratory exchange ratio greater than 1.0. Workloads were virtually identical. And so we think that we can capture peak oxygen uptake and all of the other wealth of data from a cardiopulmonary exercise test with the addition of the pulmonary arterial catheter when patients are performing maximum upright exercise. And in this protocol, we were able on average to add approximately 11 matched measurements of hemodynamics and FIC cardiac outputs. So there are differences between upright and supine, and I'll talk about them some in the next slide. This is an important study by Murat Fudim's group, as well as Italian collaborators, looking at what they termed a suprite protocol, which is performance of both supine exercise as well as upright exercise in the same individuals, which I think is really value added, because there's some labs that do all supine exercise all the time. There's others that do all upright. And we can certainly learn from this protocol where patients were subjected to both protocols. There was 36 individuals that met diagnostic criteria during supine exercise for heart failure preserved ejection fraction on the basis of a pulmonary capillary wedge pressure of 25 millimeters of mercury or more. But notably, during upright exercise, there was significant discordance in that 18 of these patients also met upright exercise hemodynamic criteria for heart failure, whereas half of the patients did not. These patients had more shallow wedge pressure cardiac output slopes, and notably the discordant group here tended to have lower H2 PEF scores, less atrial fibrillation, lower natriuretic peptide levels, less structural heart disease. And so there is a group of patients, particularly more obese patients, patients that have lung disease that are more respirophasic when you're making these measurements at end expiration, that can have wedge pressures that are elevated during supine exercise, but not necessarily upright. We need more work in this area to understand the natural history of these discordant HFpEF patients. But I think in the meantime, we learn from doing more measurements in these patients, which is the simple message than we get in the form of rest hemodynamics alone. But we can't just interchange the two necessarily in terms of supine and upright. Last slide in terms of the methodology. So when you perform supine exercise, there are significant advantages to it. You can do this in one setting, that same setting that Jim described, where you're getting your resting right heart cath measures, you've leveled your transducers, and you can do a single procedure without the patient having to relocate with addition of supine exercise to the resting hemodynamics. I mentioned zero level position, and you can also capture the excursion just simply with raising the legs in terms of some volume increase to the heart. In terms of the advantages of upright versus the supine, again, you can typically, in patients that are otherwise similar, you can get to about half as much exercise in the supine position, so you tend to have fewer measurements, particularly if you're doing thermodilution cardiac outputs and you want to keep that individual at the same workload for a period of 3 minutes. You oftentimes won't get more than 3 measurements, or sometimes only 2 measurements per individual. And then you end up putting a lot of stock in that end of exercise measurement when patients are oftentimes having the most respirophasic tracings and sometimes the most noise in their tracings. So you sometimes get fewer tracings, you have less workload. And again, you have to be careful because you can't necessarily ascertain things like chronotropic incompetence or peripheral oxygen extraction because patients aren't getting to a maximum oxygen uptake. And so you have to be careful in terms of ascribing deficits in other components of the FIC pathway. Upright, particularly if you're doing minute by minute measurements, you can make more measurements of VO2, more measurements of cardiac output and wedge pressure. So there are clear trade-offs between these two. But again, the simple message is that we gather incremental data from the addition of exercise hemodynamics, and I'll go through some of that now. So in terms of some of the early studies, these are really quite interesting to look back at, done in the 90s, where there was exercise right heart catheterizations done. Jim mentioned some scores that typically include the central venous pressure. Across these studies, it was typically integrative measurements like LV stroke work index, cardiac power output. The important take home is that if you combine what happens to stroke volume, what happens to blood pressure, what happens to wedge pressure during exercise, and you put these things together, say in a cardiac power output, then they potently differentiate patients who have worse prognosis with heart failure. These are heart failure reduced EF studies done in the 90s again. And perhaps the most elegant study, in my opinion, is one that basically just looked at how does one increase their oxygen uptake. Do they increase their oxygen uptake with a predominant contribution of cardiac output because they have peripheral impairment? Or do they have such poor cardiac performance that their cardiac output contribution is low and they have to make up for it by having essentially a supernormal peripheral oxygen extraction? And so if you have a shallow slope, it's because you can't augment cardiac output, and you have to have a compensatory response in the periphery. If you have a steep slope in excess of 5, that means that you have a primary or a predominant peripheral limitation compared to cardiac limitation. And the fascinating thing is in a HFrEF population, so patients that all of us take care of every day, Nancy's probably just got done rounding on some of them, a significant portion of these patients, 45% with HFrEF, actually had relatively steep slopes, which means that their periphery was more impaired than their cardiac output when they tried to augment their VO2. And if you look at what happens in terms of cardiac events, there was about a 5-fold difference between those that had the steep versus the shallow slopes because of the cardiospecificity of a shallow slope. So anyways, there's a lot to learn from some of these early studies. More recently, we've been more focused on what happened to the wedge pressure. And the wedge pressure is clearly very important. When we look at prognostic studies, they typically are indexed wedge pressures during exercise. So you can index the wedge pressure to cardiac output, which is what we did in this study. And we found that a wedge flow slope in excess of 2 in patients with normal resting hemodynamics conferred increased chance of developing heart failure events. And this mirrors what was found by Dorfs and colleagues, where if you had a normal resting wedge pressure, but a high exercise wedge pressure, you have a worse outcome. Even if you have a high resting wedge pressure, but you have a normal exercise wedge pressure, you actually do okay. So it's the 2 groups down here where if you have an abnormal exercise wedge pressure response, you have a poor prognosis. Importantly, this is wedge pressure indexed to workload, which is in some ways kind of a way of estimating cardiac output. Same thing goes for pulmonary arterial pressure, cardiac output slopes. A steep pressure flow slope has a PA pressure relative to cardiac output increment in excess of 3 is associated with an intermediate prognosis compared to people who have normal resting and exercise hemodynamics and those that have resting PAH as well as exercise PAH. So you can think about wedge flow slope greater than 2, PA pressure flow slope greater than 3, therefore TPG, cardiac output slope greater than 1. So now we actually have all of this data looking at wedge pressure responses to exercise, whether we look at Dorfs in 2014, the Eisman study that I mentioned, Jen Ho's study that we did together in 2020, Algam, all of these were indexed wedge pressures to workload or cardiac output. The Mayo group led by Barry found that both wedge pressure in excess of 25 as well as wedge flow slope predicted worse outcomes. So we can now kind of go to this algorithm of if you have heart failure with exercise intolerance with a steep wedge pressure response, then you are more likely to go on to develop adverse outcomes. Okay. Jim mentioned respirophasic tracings. This becomes quite important during exercise. Basically, what we found is whether you look at a mean pressure or an end expiratory pressure during exercise, as long as you're doing things very consistently, they both hold similar prognostic information. You just have a lower cut point if you're looking at mean pressures compared to end expiratory pressures during exercise. So what I'll do is I can check in to see how we're doing on time, because I want to leave plenty of time for Q&A. Maybe I'll just wrap up with this. We can learn a lot from the exercise hemodynamic profile. If we have patients that come in with exercise intolerance suspected to be on a hemodynamic basis, I mentioned the importance of measurements of pressures, measurements of cardiac output, either by thermodilution or by measured FIC, but never by estimated FIC. Whenever a patient gets sent to me that has an estimated FIC cardiac output that goes down with exercise, it's because you should really not do that, because your VO2, of course, is going up when you exercise. So when you collect this data, importantly, you can also gather information about other diagnoses that we haven't focused on yet. If you have failure to augment your pressures inside the heart, coupled with failure to augment stroke volume, this is a quite good indicator that a patient has inadequacy of their venous return to the heart. And you can see this with patients that have had post-viral syndromes. We see this a lot with the long COVID patients. We see it in patients that have obstruction of venous return, if they've got deep venous thromboses and so forth that impair the venous return to the heart. They can have inadequate preload. I make this diagnosis carefully. This is really patients who have adynamic pressure increases with inability to augment stroke volume normally, and otherwise lack of findings on their exercise test. Pay attention to the periphery. Again, an advantage of doing these studies with a maximum upright studies, you can ascertain whether patients have limited peripheral oxygen extraction. Pay attention to pulmonary mechanics, and then pay attention to relative changes in heart rate and each of the FIC variables. And then if you fall into this category of heart failure or PH, the PA pressure, cardiac output slope greater than 3, wedge to watt slope of greater than 25.5, wedge flow greater than 2. All of these are prognostic variables. Cardiac power, we didn't talk about proportional pulse pressure. So what I'll do is I have additional material that I'm more than happy to share with people, but I want to make sure we have plenty of time to get to questions. And then, we can circle back to some of these if time permits at the end. So let me stop sharing, and more than happy to take any questions.
That was great, Greg.
Thank you both. Anyone want to jump in with a question? Yeah, Ilan, please.
Thanks. I actually have a question for both speakers, if possible. So for Dr. Fang, and thank you. I wanted to, you were showing, the definitions of what CVP and wedge kind of reflect. And I wanted to ask, how do you interpret or differentially look at CVP and wedge in terms of volume or congestion management? Because it does seem like a lot of times, both with a high CVP, but also with a high wedge, we say, well, first, let's diurese the patient. And I was wondering whether you have cutoffs or values at which you dissociate the two.
Yeah, no, great question. So not exactly sure what you mean, but in general, the CVP should be technically 60% of your wedge. I'll be honest with you, I just remember 50%. It's easy. And that is that holds true as long as the right ventricle is good and there's not a lot of pulmonary vascular disease. And so you can follow the CVP as you're diuresing somebody, if that's all you have, just anticipating that the wedge is going to be twice that number. When we start to see the CVP approach the wedge, we're talking about patients who have significant RV dysfunction. And this then becomes tricky, because as you try to decongest the right heart and at the same time decongesting the left heart, you can actually overdo it. And this becomes a real challenge. And I always like to say that if in a heart failure patient, not only is a CVP, high CVP bad, the inability to drop the CVP is prognostically horrible. I'll be honest, that's a slide, like keep it simple. The worst patient you can come in and see in clinical heart failure is someone who's tachycardic with a high CVP that hasn't changed for 5 days in the hospital. That is a very bad right ventricle and severe cardiorenal syndrome. So that's a quick insight from my point of view. But I can tell you, when you see that CVP tracing and the wedge and the CVP's 10 or 12, nobody's really getting too excited. I'll tell you, that is a very bad ventricle, right ventricle, because of the rapid Y descent.
Maybe
Thank you.
just to add one thing onto that, I think, pay attention to that right-left relationship. Particularly if you've got your patients with bad ischemic heart disease, and you might have a central venous pressure of 3 and a wedge pressure of 24. That is also a patient whose left heart is in trouble. It may not be a volume issue. It's just that they really can't bring the pressure down in the left side of their heart. But I found, when you have people that get serial right heart casts done, when you're rounding on them, you can look at their jugular venous pressure, but remember that right atrial pressure to wedge pressure relationship that they have, because they can span the whole gamut. And that can be helpful in terms of your day-to-day management once the PA line is out.
If you have that patient with the low right-sided pressures and the high left-sided pressures, do you still try to diurese them?
My typical focus is on seeing if you can afterload reduce the left ventricle, particularly, if you've got the pressure room. But I think the question was, about this, like, how do you judge volume status? And I think sometimes there is that mistake some way, is that the wedge pressure is 23, but that wedge pressure is not necessarily going to go below 23 with hitting patients hard with their diuretics.
That's an important point that both Nancy and Greg are bringing up, is that pressure is a surrogate for volume in our world. You should never forget that, because sometimes we think they're equal, and they really, it depends upon the chamber, right? You don't know if you're operating on the very compliant or the very non-compliant part of the volume pressure relationship.
Thank you both.
Yeah, I think we can move to Junaid.
There is a question here. I'm just going to read through these, Dor. Maybe that'll be helpful. There are a bunch of questions in the chat. It says, do you use the FIC or the thermo? I briefly touched on that. So at the University of Utah, everybody gets both. And we always like to defer to the clinician. They both have their issues. I showed you very briefly the original Damer paper. By the way, the way Damer and Dave Hillis at UT Southwestern got the oxygen consumption was they worked backwards. They calculated the cardiac output from thermodilution, had the AVO2 difference, and multiplied the two. And they got ranges from 50 to 250, and 125 is in the middle. And I love that. I don't know if I showed you that quote. They quote in the paper, the last line of the paper is, don't use it. It's not reliable. It's untenable. And every lab in America uses 125. And by the way, they did show that sedation has an impact. No big surprise. Oxygen consumption goes down when you're sedated. They suggested there was no difference between men and women. If you look at the original numbers, the numbers are tiny. And it turns out that in women over 60 or 65, their O2 consumption at rest is about 10 cc's. 10 cc's different per minute per meter squared. So, age didn't make much of a difference, by the way, but it's fascinating to know that the Damer approximation was generated from thermodilution. Let's see what else here. I don't know. Does anybody want to tackle this? Dr. Song asks, how accurate is to use a FIC from a PIC line or right IJ central line? Anybody want to? So the short answer is, with a lot of assumptions, you can trend it. Because the SVC SAT, if anybody remembers the FLAM equation, the SVC SAT is the predominant venous SAT that measures the systemic venous return. The reason we call the PA SAT the mixed venous is because you're measuring the venous return from the upper body, SVC, the lower body, the IVC, the coronary sinus from the human heart itself, and then bronchial. So it's really 4 venous returns giving you the SAT and the PA. But if you look at which one of those 4 SATs dominates the mixed venous, it is the SVC. And it should be less than 7 absolute percentage points from the mixed venous. So if it's more than that, there's an intracardiac shunt or there's something wrong. So you can trend it, but don't draw a venous SAT from a peripheral IV. All it tells you is the oxygen extraction of the muscle group distal to where your IV is. So if you draw from a midline, all you're finding out is the venous return and the oxygen extraction from your hand. But if the PICC line is on chest X-ray and the SVC or right atrium, you could use a poor man's.
I think we have some people that raise their hands. I don't know if they want to jump in. Olivia?
I assume that's me. Hi, I'm Orly. I just have a kind of like a more of a curious question. I did my advanced, just graduated from my advanced heart failure training at University of Chicago, and we, the guys over there are very big on these kind of novel advanced hemodynamic parameters, such as the aortic pulsatility index, the CPO, myocardial performance score. And I'm just wondering, what are your opinions of that? Do you think those are kind of ready for prime time, or do you think there just needs some more studies to kind of generalize? And do you consider those in your practice?
Well, I've been doing a lot of talking. I'll give you my opinion after I hear from Greg and Nancy.
Yeah, I'll try to give a, I guess, somewhat open-minded answer to this. So, I think that those types of parameters you're talking about, if it means that you're carefully considering each component variable and what they mean and looking at the primary data yourself, then I say all for it, right? Because, of course, integrative measurements can be helpful with hemodynamics. I showed some of that for exercise, cardiac power output. When you integrate stroke volume and wedge pressure and things like that, then it can certainly be helpful. I find like the pulse, the PA pulsatility index to be, we do walk rounds every morning with our, surgeons and our cardiologists, and we go and see patients briefly. So that's great for walk rounds. So you can see it from outside the door, right? And you can kind of get a sense of what's happening with that patient. Is their pulsatility adequate? Is their right atrial pressure nice and low? So yes, I think having a broad perspective on different ways of thinking about hemodynamics when you're thinking about them and when you're reviewing the data primarily is good. But I think sometimes people can get a little bit caught up in combining the variables, and sometimes they don't even always make a lot of sense in terms of what direction the patient's going in. If you have a patient that has a RA pressure of 4, then that RA pressure goes to 20, you may calculate even your SVR differently, right? But you have to think about what does each individual component variable mean in terms of what direction the patient's going in.
Yeah, I will just ask that, or add that I think all of these are tools to help us make the right decision for a patient who's in trouble. And the most important thing, I think, is understanding the limitations of your tools. None of these are perfect, and none of them are right all the time, and none of them give you the answer. And so you have to use those data in the context of the patient in the room. Greg just mentioned standing outside the room. And I think sometimes we stand outside the room, make the numbers as perfect as we can, and nobody's actually looking at the patient. So it always should center around the patient and how the patient's doing and understanding. And, this is the beginning of your advanced year. If you're a new fellow, spend your year understanding these tools and where they're helpful and when they don't work. That's so important.
Yeah, so my take on it is a combination of what Greg and Nancy said. So understanding these ratios and what they mean. So the APIs is simply a pulse pressure divided by wedge. So what you're doing is normalizing stroke volume, pulse pressure as a surrogate for stroke volume, by preload. And the performance of the human heart is really defined by the ability to deliver stroke volume for a given preload. That's what API is. So if you can actually generate a large pulse pressure with a small wedge, it's a good ventricle. On the other hand, if it's a small pulse pressure with a high wedge, it's taking a lot of preload to generate a very small stroke volume. So that's intuitively how we think about these things. What the actual value is probably less important as you understand what that's the whole concept. CPO or CPI is in many ways just how much work your heart can do. It's basically it's cardiac output times mean blood pressure. The reason you divide by 451 is because a mean of 90 times a normal cardiac output of 5 is 450. That's why a normal CPO is 1 watt. So it's super intuitive if you just understand what the numbers are. It's not a mystery to you. And obviously somebody in whom either the blood pressure is low or the output is low or both, if they're both low, that's going to be a darn low CPO. The cutoff people use is 0.6, if you index 0.3. But again, these numbers, the cutoffs really don't matter as much in clinical practice as you understand what they're trying to do. They're just combining two different aspects of the system into one integrated number.
That's excellent. Maybe we'll have like 1 or 2 more questions. Maybe Quentin?
Yeah, hi. Thanks so much for the awesome talks. This is Quentin Humans at Northwestern. I had a quick question for Dr. Lewis related to, exercise hemodynamics and interventions that can help to intervene. So do we know how SGLT2 inhibitors, for example, or other medications that we use to treat HFpEF actually might bend the arc in terms of patients who have primarily exercise-induced elevation in pressures and HFpEF that came out during exercise?
Yeah, thanks. That's a terrific question. I would say the answer to it is partially. There has been, one of the issues with the SGLT2 inhibitor studies, and I'll just share my screen real quick again. Let me know if you can see it. Is we've looked at this recently in terms of exercise hemodynamic values, and basically, if you identify a group of about 500 people that meet exercise hemodynamic criteria for HFpEF, and then you apply the SGLT2 inhibitor study criteria for them, you end up excluding about 80% of these patients. So the person that has a right atrial pressure of 4 and a wedge pressure of 9 at rest, and then you exercise them and they have an abnormal exercise hemodynamic profile, they may benefit from SGLT2 inhibition because they may be kind of on their way to heart failure, right? We know these things predict future outcomes, but we have to be a little bit careful because they're not the same congested patient, the patient that had that high natriuretic peptide level that got them into the SGLT2 inhibitor studies. So if we take a strict kind of evidence-based approach, we can't say that the SGLT2 inhibitors by definition are going to work for everybody that has exercise unmasked elevations in their wedge pressures. But it stands to reason based on the role of these drugs in potentially preventing heart failure that if you trial them on an SGLT2 inhibitor, you may be doing them a great service. But there is a subset of these patients because they're only with exercise, they don't necessarily have that same degree of volume retention that our other patients have. So I hope that answers your question. I think there's a huge unmet need to address this large group of individuals who you can unmask heart failure, perhaps an early form of heart failure, perhaps a more treatable form in some ways. But we don't have the evidence from the studies that have been done to date to say definitively, that we're going to benefit them.
Thanks so much. Really appreciate it.
I just want to ask one more question that I see in the chat that I think it's going to be interesting to hear the two of your, thoughts about, labs that don't have exercise capability. What are your comment on leg raise or volume load and assessing HFpEF or dynamic changes?
I can start off with this one. So I would encourage you, we do unbelievable things as cardiologists, right? The types of procedures that are done on patients, the, total valves that are put in, we do unbelievable things, putting shunts between different parts of the heart into the coronary sinus. So I would challenge you as the kind of future leaders in cardiology and in heart failure to develop the capabilities to make measurements during exercise. Certainly during a right heart cath, there is absolutely incremental benefit from having the person exercise. There's a question I saw in the chat about, do we have an arterial line? We see a lot of patients with undifferentiated dyspnea that have gone to 3 or 4 different specialists. You can't figure out what's wrong with them. And so we basically kind of roll out all the stops to get the most precise data possible. But no, not every single person necessarily has to have that A line. You're going to gain incremental information, in my mind, if you just have them do those additional hemodynamics. Yes, there is a role for leg raise, certainly volume, but perturb the system, because you really do learn a lot more about your patient under those circumstances. And this is perhaps a little bit controversial, but I can't tell you the number of patients who have wedge pressures of 17 in the supine position, and they come to the lab and they're upright and they are not limited by their wedge pressure at all. They're limited by other factors. And so, the more you can learn about your patients, I think the more that we're going to be in a better position to help them going forward.
I couldn't agree more. You have to do some kind of challenge. You have to challenge the heart in the cath lab in some way. So we will turn up pacemakers. So just have, for example, we'll atrially pace at a heart rate that's just higher, just to see what happens with heart rate alone. I mean, you just got to do something. For example, we will even try to get the patient's heart rate up by just moving their arms. You just want to see what happens with some kind of intervention. This happens a lot in HFrEF. You have patients who are complaining bitterly of dyspnea. You do a right heart cath 3 times and all the filling pressures are low, right? And then somebody says, well, why don't we exercise the patient? And then the patient with HFrEF with a wedge of 10 goes to 30. And you're like, okay, the patient's not crazy. You actually have a objective piece of evidence that describes why they have some exertional intolerance. So yeah, I agree, giving volume is not frankly the best thing to do. As it's, unless you're putting in the volume quickly, it's not frankly a meaningful test. Barry showed clearly that it's not nearly as good as exercise. So
Yeah, and I'll just add that, resource constraints are real, and but especially as you become an operator and you are doing the right heart cath, so get to know your nurses and get them to really like you, so that they're willing to do stuff for you, so that you can do something as simple as sit the patient up on the edge of the table and have them re-zero the transducer and see what happens when the patient changes position to their filling pressures, and then give them 2 IV bags and have them do arm raises. Most deconditioned heart failure patients, that's a significant stress, right? If just moving their limbs isn't enough of a stress, you give them 2 IV bags and, it's like doing arm curls. They can't do it very long and you'll get the response. But I agree that I think leg raise and fluid challenges, if they're wildly positive, are helpful. If they're negative, it's not helpful. It doesn't tell you that their pressures aren't going to go up in reality with exercise.
I think that's excellent. Thank you all of you, James, Greg, and Nancy, for this wonderful session. We are 10 minutes past 9 and we already still have 76 people on the call, so it means a lot. And I'm really, really excited that we kind of kicked off this first webinar series with these wonderful talks. If you have any more questions that you want me to address and send to the speakers, please email to me or Sarah, and we will definitely make sure that you get answer. And I'll see you all in next month in our next session on cardiogenic shock. And for the next time, we will have your video, cameras on, microphone on, and we'll be more kind of like in a friendly environment that we can have like a truthful communication and a good discussion. Thank you all.
Thank you for coming.